The properties of zirconia from a clinical perspective, a NEOM webinar from 2021. In the strive for metal-free reconstructive materials, oxide ceramics came in the early 1990s. And even though some of the materials used then were considered to be high-strength ceramics, there were limitations that made it impossible to use the materials for larger reconstructions that may be 3-unit reconstructions. Then in the mid-1990s, yttrium oxide stabilized zirconium dioxide came and was used in combination with the porcelain that gave the reconstruction a more tooth-like appearance. The mechanical properties of zirconium dioxide was quite exceptional. So if you compare the mechanical properties to other ceramic materials, we had now a material with quite high strength values and very tough properties that made it suitable for even larger reconstruction than before. One drawback was, however, the optical properties of the material that made it necessary to combine zirconium dioxide with porcelain, a porcelain that constituted the weak link of the reconstruction. So if you look into clinical studies since then, we have tooth-supported reconstructions and implant-supported reconstructions in quite many studies today. And typical findings in the early clinical studies was that there were no fractures or very few fractures in the frameworks. But on the other hand, there was some drawbacks with the porcelain, and that was chip-off fractures. Approximately 15% of chip-off fractures were seen in quite many clinical studies from that time. So what was the reason for the chip-off fractures? Firstly, when we started, we used CAD-CAM technology that wasn't as developed as the CAD-CAM technology is today. And for that reason, it was not possible to make reconstructions that gave the porcelain proper support. And if you look at the slide on the right side, or the picture on the right side, you can see that this is the optimal design where you have a framework that gives support to an evenly thick porcelain layer. But with those days CAD-CAM technologies, that wasn't possible. The shape of the reconstruction was not good enough, meaning that the porcelain sometimes became too thick and thus prone to fractures. So if we look at the effect of the porcelain thickness on fracture strength, then we can say that if the optimal porcelain thickness is 1 millimeter, and we consider this to be 100% in strength, and we compare it with less porcelain or thinner porcelain, as for instance 0.8 millimeter of porcelain, then you lose approximately 15% of the strength. And if you decrease the porcelain thickness, you will lose strength as a consequence of that. And even more, if you increase the porcelain thickness, then you lose even more strength. So if you go from 1 to 2 millimeter, then you lose approximately 40% of the strength of the porcelain. And that is, of course, not acceptable. And this goes on when you increase the thickness. So consequently, you need to have a well-supported porcelain with even thickness to avoid porcelain fractures and to be able to withstand the loads that we have under function, that we see under function. So with a core with a strength that is maybe 10 times the strength of the porcelain, we can say that the veneering porcelain is the weak link of the reconstruction. So what if we exclude the veneer? If we make the zirconium dioxide a little bit more translucent so that it resembles the natural tooth structure a little bit more, from an optical point of view. Could that be a solution to the problem? First of all, we can take a look at how do we gain translucency. Translucency is normally gained by tampering a little bit with the grain sizes of zirconium dioxide. The reason for the zirconium dioxide to be less translucent is actually that every time light passes a grain border, it will get dispersed, and that will reduce translucency. And by increasing the grain sizes in the zirconium dioxide, you reduces the number of grain border passages, and in that way you avoid light dispersion, and you get a material that is a little bit more translucent. So by doing this in combination with increasing the cubic proportion of the material and reducing flaws and the numbers and size in the material, you will get a zirconium dioxide that is more translucent, and then you might be able to exclude the need of porcelain. So if we consider the first generation of zirconium dioxide that was used in combination with porcelain as the first generation, and we use this as a gold standard, and we say that the strength of the material is 4 out of 4, then we have poor translucency, only 1 out of 4. And if we compare it with the newer generations, then we can say that the second generation that came 2009 have still the same strength approximately, but still quite poor translucency, something like 2 out of 4. Then in 2014 we got the third generation. The third generation, now we had quite high translucency, but we lost a lot of the strength and the toughness in the material. So the balance between strength and translucency wasn't good enough. And then in 2017, we maybe got the balance that we needed. We now have reasonable strength and reasonable translucency. So this was maybe the solution. So what are the clinical implications of that? But you can say that traditional zirconias are materials that can be used with great confidence for quite many clinical situations. And if you look at the translucent zirconium dioxide materials, you can say that both translucent and high translucent zirconias are promising, but long-term follow-up studies are still lacking. And for that reason, the choice of material should be done with great care, using materials only that are known for the clinician. And the problem might be that if you look at the market, then you can see that there are so many different translucent zirconium dioxide materials. They can be called translucent, high translucent, super translucent, ultra translucent, or maybe top translucent. And how should you know how to navigate in this jungle? If you look at all brands available on the market, then you can say that there is a fracture strength range from 600 to 1500 megapascals. And there is a range of fracture toughness in between 3 and 10. And that is, of course, a vast difference when you compare different materials. So another thing to consider is, should you use the material that are the most translucent materials, or should you get aesthetic properties in another way? So by choosing a material that is a little bit stronger, maybe, that is translucent, but maybe not as translucent as you would like it to be, then you can balance the mechanical properties with the aesthetic expectations by making another type of reconstruction, where you actually don't use it monolithically, but you add a porcelain. You make a buccal cutback, and then you have the strength of the material in the frame, and then you can add aesthetic properties by adding a buccal porcelain. So if you look at this CAD picture, you can see a reconstruction that was made in that way or designed in that way. And this is what you might call a semi-monolithic translucent zirconium dioxide reconstruction, where you have a buccal cutback. So the reconstruction is made in a strong material, translucent, but maybe not the most translucent material that we have. And then you gain even more aesthetic properties by adding a buccal porcelain, where you don't expect that the loads will affect the material. So this is the same reconstruction, but now finished on the model. And now you can see that on the buccal surface we have the porcelain. And if we look at the same reconstruction in the mouth of the patient, then we have the occlusal surface completely in zirconium dioxide. And you can see the demarcation line between the porcelain and the zirconium dioxide. And then you can imagine that when the patient chew, the patient only chew on the zirconium dioxide, and the connectors is made out of zirconium dioxide. And then the buccal porcelain is adding aesthetical value to the reconstruction. Another important thing to consider is the design of the reconstruction. Since it's easy to think that if you make a monolithic reconstruction where you don't have to gain space for the porcelain, then it's easy to get a strong reconstruction where the complete reconstruction is made in the strong core material. But the shape is also very important. And that means that if you make the separation between the different units in the core material, you actually add fractural impressions that can be that can lead to fractures of the connector areas. And when you have the porcelain, as you can see on the picture on the left side, then you make the separations in the porcelain, and then you avoid the fractural impressions. So actually you get a stronger shape when you have porcelain compared to when you have monolithic reconstructions. And then you can see on those pictures that on the left side you have a reconstruction with very blunt separations. And the blunt separation makes the reconstruction stronger compared to the picture on the right side, where you have very sharp separations. And what does this do to the strength? But look at the load-bearing capacity here. It's quite high, or at least if you compare to the load-bearing capacity with that design, it's less than 50%. So this design is very crucial to avoid to get strong reconstructions. So maybe you should use the space that you have to increase the connector dimension and to be sure that the design is correct. Another important thing to consider is the cervical preparation. If you make a chamfer preparation, then you will have a thick cervical ring of your reconstruction. But if you make a very thin preparation, like for instance a slice preparation, you will make a shape in the cervical area that leads to fractal impressions in the porcelain. And that means that the cervical ring will be so thin that those fractal impressions will start a crack growing from this area, and you will get a complete fracture of your reconstruction. And by knowing that the stress concentrations in the cervical part is very high, it's actually sometimes the highest stresses that you have in a crown, then we need to dimension the cervical area sufficiently. And that means that we should have a chamfer preparation at least, and it should be 0.5 millimeter if you have monolithic areas. And in the areas where you would like to add a cutback with porcelain veneer, then we need at least 1 to 1.2 millimeter of depth of the preparation. Then we have some more aesthetic options, and that is staining. And by using staining, you can actually add color to the reconstruction. And this could be made in two different ways, either by having color of the material already from the start, or by using infiltration staining, like you can see on the slide, on the picture on the left side. Then we have multi-layer options, And the multi-layer options can be seen in two different ways. And the one is that you have one and the same material, but with different color gradients in different layers of the material. Another way is to actually have different materials with different properties, different translucency properties and different strength and toughness in the different layers. And that is quite different from the first one. And if you look at brand A and brand B on this slide, you can see that brand A, which is a material with a color gradient, you have actually the same strength in all layers. But in brand B, where you have a true translucent layer, you have an enamel layer that is less strong compared to the body material. And that is something that can be used if you would like to gain the most optimal aesthetics, but you lose some strength in the most translucent layer. I will end up with showing a couple of cases, and this is a young girl that was treated a couple of years ago, and this is of course an aesthetic case, so it's a challenging situation to find a material that is suitable for this patient. In this case, we used a CAD-designed preshape for evaluation of the aesthetics, and the CAD-designed preshape should be identical in shape to the permanent reconstruction to allow for evaluation of the preshape. When you're satisfied with the shape, then you can continue to make the permanent reconstruction, to transfer the shape to the permanent reconstruction. And in this case, it's a reconstruction that is milled in a multi-layered zirconium dioxide material. This is completely monolithic without any porcelain. And now we check the shape, and we check that we have a gingival radius of 0.6 millimeter or more, that we have moderate separations so that we will get the strength that we need in the connector areas. And of course that the connector dimensions are sufficient, and in this case is 3 squared 2 millimeters since it is in the anterior region. The connector dimension should be 3 squared 3 millimeter in the premolar region, and if it is in the molar region, it should be 4 squared 4 millimeters at least. That is the minimum dimension. So the day of delivery, it's time to check that the permanent reconstruction have the same shape as we decided with the pre-shape, and we place it in the mouth of the patient, and now we can see something that looks like this. This is again a completely monolithic translucent zirconium dioxide reconstruction made out of a multi-layered material. And of course it is in a challenging position, since the patient shows quite a lot of the reconstruction. This is another case just to show you a little bit what the challenges could be. And when you have a case like this, it doesn't matter if you use porcelain fused to metal, if you use traditional zirconium dioxide, you will get problem with the porcelain. So one can ask if possibly monolithic zirconium dioxide is something that could be used with a little bit more of knowledge in a case like this. And for this patient, this is a 1-year follow-up. And you can say that since the patient still is a heavy biter, then you don't see any signs of wear after 1 year in the mouth of the patient. So this might be very promising, but we should remember that we don't really know yet, because we don't have the clinical follow-up studies for this kind of treatments. But it looks very promising. Finally, what about CAD-CAM and implant-supported reconstruction in a case like this, where you have a full arch reconstruction? Well, let's take a look at a case where we use the other combination, the combination where we have porcelain with cutback technique on monolithic, or in this case semi-monolithic zirconium dioxide. This was the case. In this case we also use a preshape. This preshape is made from CAD-CAM, where I have made thorough measurements and registrations in the mouth of the patient. And I deliver this to the dental technician, who make a CAD, and from the CAD he make a preshape. And you can see the preshape on the picture to the right. So now it's time to mount the preshape in the mouth of the patient. Then I make thorough occlusal adjustments, and the patient have the preshape in the mouth, and we leave it there for a fortnight, and then the patient comes back. We check aesthetics, phonetics, hygiene, function, and comfort, and so on. And when we are satisfied, we demount it again, and we send it back to the lab. And at the lab, the dental technician rescan the preshape, and then the dental technician make a superimpose, where the CAD program is taking all the changes from my adjustments and placing it into the original design. And now we can make the permanent reconstruction with all the occlusal adjustments and so on. All the changes that were made in the clinic is transferred to the permanent reconstruction. And then the dental technician starts to produce the permanent reconstruction. And this is the reconstruction, as you can see, in different steps. So it's milled, it's stained, it's sintered, and then the dental technician make the veneering of the reconstruction. This is the day of delivery, and this is how it looked when we delivered it to the patient. And since you should always follow up your patient, this is 4 years later. And I had the opportunity to see the patient some time ago, and now you have the 6-year follow-up. And this is semi-monolithic, translucent zirconium dioxide, where the buccal surfaces and the gingiva is made from a traditional porcelain that is, of course, adopted to the Zirconia material. And by showing you this picture, I would like to thank you for listening and saying good luck out there.